Hello, we would like to share a method for determining optimal tracheal stent size using measurements derived from computed tomography. We have no conflicts of interest. When placing a stent to manage tracheal collapse, the device diameter is selected based on maximal tracheal diameter. However, stent length after deployment is determined by the overall diameter of the stent when in place. It should span all of the affected area and ideally extend from 1 centimeter caudal to the larynx to 1 centimeter cranial to the carina. However, predicting post-deployment stent length can be challenging. The stent manufacturer supplies information regarding expected length when deployed for each specific stent. This slide shows the shortening information for one particular stent, a 12 by 65 millimeter device. If this opens to an average of 9 mm, the stent will be 90 mm long. However, if it opens to 11 mm, it will be 74 mm long. In previous work regarding stent sizing, Monaco et al. Showed that segmental measurement techniques using radiographs were fairly reliable, although final stent length was 10 to 13% different from that predicted. In a study using unaffected cadavers, Montgomery et al. Showed that CT-derived measurements were superior, as tracheal diameter was consistently underestimated radiographically. Williams et al. Compared tracheal diameter measured using fluoroscopy versus CT in normal dogs, and showed that CT measurements were larger and more accurate. Our objectives were 1. To devise a quick, simple and reliable method to predict post-placement stent length using measurements from computed tomography, and 2. To compare predicted stent length versus actual immediate post-placement stent length in a cohort of dogs undergoing stent placement for tracheal collapse grades 1, 2, and 3. We excluded dogs with grade 4 tracheal collapse, now often referred to as tracheal malformation, as those cases were unlikely to fit our model. First, we compared different windows for ease of measurement and found that the abdominal window was preferable. During CT scanning, the endotracheal tube was placed just inside the larynx and positive pressure ventilation was held at 20 centimeters of water. We determined tracheal diameter at 4 anatomical landmarks: 1 centimeter caudal to the larynx, the thoracic inlet in line with the cranial end of the manubrium, midway from the inlet to the carina, and 1 centimeter cranial to the carina. To determine final stent diameter, we need essentially to convert an ellipse into a circle. This can be calculated from the major and minor axes, or image processing software may allow for measurement of the perimeter. However, an ellipse cannot be reliably transformed into a circle with the same perimeter. Calculating from the axes is therefore preferable, and the diameter is simply the square root of the product of the two axes. Tracheal height and width were determined twice at each location from stored images using measuring tools in Fujifilm Synapse. A spreadsheet was used to determine the average tracheal diameter, shown here in pink. We created regression curves for each stent size so that we could get very accurate measurements of stent length from predicted diameter. So using the 12 by 65 millimeter stent as an example, if predicted diameter is 8.6 millimeters, predicted length is 91.6 millimeters. This method was retrospectively validated using stored images collected immediately post-stent deployment. We used images from patients with a measuring catheter in the esophagus. This was used to calibrate length within the imaging system software and thereby determine in situ stent length. This was done in triplicate and averaged by one individual. This graph shows the difference between predicted and actual length for each of the 11 dogs expressed as percentage. Discrepancies ranged from 0 to 5.44%, with a median of 2.32%. In 10 of 11 dogs, the difference was less than 5%. In summary, our findings indicate that immediate post-placement tracheal stent length can be reliably predicted from CT imaging using 4 specific locations in dogs with tracheal collapse grades 1, 2, and 3. These references are pertinent to the work shown here.